So welcome everybody, and welcome particularly to Craig, who's the co-chair of the Sarcoma Advisory Group for London and the South East, and he's CD at the National Orthopaedic Hospital and Professor of Orthopaedic Oncology at UCL. So Craig, wonderful set of titles. Thank you so very much for joining us, you and your team. And he's going to take us through the diagnostic pathway for adult soft tissue sarcoma. Thank you very much, Craig.
Thanks, Claire, and thanks for the invitation to talk about this pathway, which has raised a little bit of discussion and controversy over recent times, I think, and a little bit about how it hasn't really worked brilliantly and how we're trying to improve things, and of course, quite a bit about the patients. Yeah, that's me. Yeah, the reason for this webinar in particular is because we're trying to remodel the referral pathway for patients with possible soft tissue sarcomas. So the aim is to raise awareness, try and go through some of the referral or some of the patients you might refer to the pathway, what's appropriate and what isn't. There have been a lot of changes, particularly with local diagnostic facilities and with local diagnostic services for sarcoma, which we've been developing. And obviously there's an opportunity, hopefully, to have a bit of discussion about things. Of course, one of the major issues here for patients is the hit rate, or the diagnostic hit rate for 2-week wait referrals for sarcoma, as it is with other 2-week wait referrals, is very low. And I appreciate that's a kind of policy objective in order to try and upstage, or downstage rather, cancers at diagnosis. But it does lead to a whole lot of anxiety, travel cost, and difficulty for patients. And I have to say, some of the patients that we see at our end who are the most distressed, the ones that have been referred to a sarcoma service, don't really understand why, and then turn out to have a benign diagnosis. So bone and soft tissue sarcomas are rare, less than 1% of all malignancies. And in common with other rare conditions, the diagnosis is often delayed. Patients often have a misdiagnosis. The treatment that they have is highly specialized because it's rare. So in particular, the surgery for bone tumors is highly specialized commissioned, which means that it's commissioned at a national level in 5 centers in England, and there are slightly different other arrangements in Scotland and Northern Ireland. The way care is arranged is in sarcoma networks. And so I'm involved in chairing the London and South East Sarcoma Network, which represents about 24 million people for bone tumours. And between 2 services, the Royal Marsden and RNOH, we take between 10 and 12 million of population each. So that means obviously a large geography. And it also means a large number of patients who have lumps and bumps who end up coming to our services. So of course, they're very diverse sarcomas. They can occur at any age and in almost any anatomic location, but the bulk will occur around the pelvis and extremities and the trunk, and those are the ones that I would see as an orthopedic surgeon. Some are in the skin, some are in the retroperitoneum, and there's occasional very rare tumours in the head and neck, and so on. Some are in the breast, so we see angiosarcomas within the service after patients have had radiotherapy for breast cancer. And some awareness of that is probably important for patients who have radiotherapy for breast cancer. And so you can see that one of the things we have to manage at our end is a very diverse network of care providers, so that we can make sure people get appropriate sarcoma care in terms of the overview of their condition, but also that they would get access to the correct specialist surgeons in particular. So that's quite we run for quite a complex network of people who provide care. So diagnosis is often delayed. There's often misdiagnosis, and we'll find, we often find patients who have consulted people on several occasions in the community before they come to us, and often they've been given a label of either a symptom or of some other condition without good evidence to back that up. And once those alternative diagnoses have been offered and a label is applied, it's very difficult to reverse that. Patients have difficulty accessing care because it's a long way to travel. Because these are rare, there's some uncertainties about aspects of treatment. Clinical trials are difficult. They tend to be multinational. And survival, well, the traditional mantra is that survival is not improving. But actually, we have seen some improvements in, for example, osteosarcoma survival in patients in the UK, but not the big step change that was seen in the 1980s with chemotherapy. And so we're hoping that by improving diagnosis and improving trials and so on, that survival will improve. But that's been the kind of standard statement in most sarcoma talks for the last decade or so. But of course, here's a load of lumps and bumps, and only one of these is a sarcoma. And so it's very hard to pick out which one needs to come to us urgently. And so that is the problem. From the patient's perspective, the rare people are often incorrectly reassured. We talked about that. They have to travel for treatment. We're very lucky to have some really excellent charities working in the field of sarcoma. And they tend to help us fill in the gaps around NHS provision. So, for example, within the sarcoma networks, we have an annual meeting in order to try and keep the service specification up to date. And that's a meeting that is supported by Sarcoma UK rather than the NHS, although you could argue it's a core NHS function. But these charities are very strong advocates for patients. They get many phone calls and their helpline is full of patients ringing up asking, am I being treated by a sarcoma MDT? Have I been sent to an appropriate place to have my possible sarcoma investigated? And that's quite a common question, to which end Sarcoma UK are undertaking a mapping of all the diagnostic and treatment centres for sarcoma in order to be able to give patients that reassurance. That's really tough because with community diagnostic centres and other things like non-specific symptom pathways, it's obviously pretty tough for them to map that. It's a very dynamic situation. And in fact, that when I saw the map presented last week, it didn't have Wood Green on it. Now, Wood Green is in north central London and has been set up initially as a pilot to try and help us with some of these diagnostic investigations. And I think Mustafa might be on the call and he'll be able to answer questions about that in particular in due course. So specialist care maps to specialist centres. So there are two in London, and the most relevant one is for North Central London is RNOH. So we would traditionally take all the 2-week wait referrals. We also work in other hospitals. So, for example, if you have a sarcoma of the chest wall, I would travel, for example, to Brompton and work with the thoracic surgeons there in order to make sure the patient has access to appropriate sort of site-specific care. We also see sarcomas in the spine, and we see them in the abdomen and retroperitoneum. Okay. So this is the problem from our end of the telescope, if you like. So referrals have increased every year. So on the right, we've got some graphs there. So you'll see that in 23-24, we received in the London Sarcoma Service, most of which is at Stanmore, about 8,500 referrals. So that's gone up year on year since 2019-20. So we're seeing, oh, hang on, there's something in the chat. Is anyone else just seeing the introductory slide?
No, I can see slide 9 now. I can
Okay.
see the slide that you're currently on.
Okay, looks like
Rebecca
Unverified is having a problem. So sorry, Rebecca, I'm gonna I'll keep going if that's all right. So yeah, 8,500 referrals a year. About half of those are 2-week waits. Yeah, so about nearly 4,000 of those are 2-week waits, and the others are tertiary referrals. But the number of sarcomas we're getting is pretty standard. It hasn't changed in particular. and that causes us problems. And so when we look at the number of MDT discussions we have, and there are several MDTs within the service, there's the main sarcoma MDT, and then there's a thoracic one, head and neck one, and so on. In 23-24, we had nearly 11,000 patient discussions around sarcomas. And that means we're running MDTs with 100, 150 patients in, which is really, really inappropriate and not fit for service, so not fit for purpose. So this huge number of referrals that we get causes us a problem with our core business. This is national data from the National Rare Disease Registration Service, which looks at the number of 2-week wait referrals for sarcoma, which is the dark green, and then the light green at the bottom is the number of sarcomas, and the top line shows the conversion rate. So the conversion rate for any cancer for a 2-week wait referral for sarcoma is down to so 6% there for sarcomas. For a sarcoma per se, it's something like 2.5%. So literally, we're getting a huge number of referrals for patients who don't have cancer. It's also led to problems with meeting the 2-week wait standards. So we've been in a fortunate position in the north where we've been able to scale up, and we're managing to still hit the 2-week wait targets. So we have clinical nurse specialists who do their best to triage referrals, have access to clinical support, can go straight to tests. So we do a lot of initial scans, and then we try and get people to that you don't have cancer point as soon as we can. But it's, it remains extremely challenging to do that. In the south of the region, at the Royal Marsden, they were also faced with this problem, and unfortunately they were unable to scale up, and so had a real problem in terms of hitting 2-week wait and other targets as a result of this. And so it was quite clear that this kind of system is not working both for patients and for the specialist providers. So we worked with NHS England, with Daisy and others, to try and develop a more appropriate way of managing patients. In other words, can they have better or more rapid investigations closer to home, and then only the people who need it come to the centre? So we had thought that would improve patient experience. We'd be able to better use local diagnostic pathways. And the thing that's run in parallel to this initiative has been the rolling out of community diagnostic centres, such that whereas we used to get a lot of referrals without any imaging, we're now in a position to say we won't accept any referrals without some imaging. So they must have at least an ultrasound. We're hoping this would reduce the diagnostic burden on our service, would improve performance against cancer wait times. But actually, more importantly, if you live a long way from Stanmore and you probably have a lipoma, then it makes much more sense to have a scan locally quickly and get that reassurance that you don't need any further treatment, and then be referred in only if you need to. So we developed a specification for a sarcoma diagnostic service, which means that a 2-week wait referral could go to a sarcoma diagnostic service, could be tracked appropriately and worked up appropriately, and then referred on if necessary. In terms of rolling these out, most of these are in the south. Actually, most of these are in the south. So Southampton, Portsmouth, Brighton, they all run services that are like this. Croydon runs one as well, and Croydon will send to us things that are more appropriately orthopaedic than would go to the Marsden. So hand and feet tumours and bone tumours would come to us from Croydon. Although I have to say the bone tumour diagnostic pathway is slightly different, and the Marsden doesn't participate in the bone referral pathway. There are big areas that are not covered, like the east of the region, like Kent. There's a service at Mile End that has opened. And as these services embed, they're seeing more people, but there's still people are having to travel. Even there's nothing in Kent, they're still having to come into Mile End, for example. In the north at the moment, what we have access to within NCL, what we have access to is rapid diagnostics. That's not on a 2-week wait pathway, so you should be able to get rapid scans closer to home. So if you see a lump, that you think is a lipoma, you should be able to get an ultrasound to confirm that close to home without activating a 2-week wait pathway. But for patients that are for patients where you're worried in particular about a sarcoma, and so we would say definitely patients who have previously had a sarcoma for sure. So if you think they may have a local recurrence, or then they should come straight to us really. Patients who have fungating tumours, again, would be happy to see those if there's a feeling there may be a sarcoma. But the majority should have imaging before they come to us. So here's the pathway written down. So in primary care, you should be able to get a direct access ultrasound. If it's benign and it's a straightforward lipoma, that's your job done. One of the problems we've found is that, and you'll be familiar with this, is that third-party providers in particular will do an ultrasound that says, this is almost certainly a lipoma, but hey, you can't be sure it's not a sarcoma, and that is not particularly helpful. We did develop standards for ultrasounds for soft tissue malignancy through the British Sarcoma Group, which have been widely disseminated again by with support from Sarcoma UK, and they would be we often send those out. I think in general, the general position, and which I think is quite useful, is that to get a proper ultrasound, you ought to be somewhere where, if necessary, that person can escalate to an MRI scan. Because if there is some doubt about what is a subcutaneous lipoma, or it's very large, then an MRI scan is the thing the patient needs next. The risk of malignancy in a subcutaneous lipoma of any size is extremely small. So there tends to be, there have traditionally been 5 or even 8 centimetre cutoffs for subcutaneous lipomatous tumours, but actually the risk of cancer in these is tiny, whatever size they are. But once they get over a certain size, be it 5 or 8 centimetres, they should have an MRI scan, and that would usually sort that out. The deeper ones, the ones subfascial, they also need an MRI scan. And we often do speak to patients about those. So if you have a large, deep lipomatous tumour, we'd be happy to see those, although on a non-urgent basis, and we'd usually then have a conversation with the patient about excising them or leaving them alone, because there is a risk of malignant change in those, and we do see that from time to time again, although it's unusual, but patients need to have that information. So the patient has an urgent ultrasound, and then they would go to a local diagnostic spoke. So if there was a question about it, they would go where they would be able to get an MRI scan and possibly a biopsy in the spoke, and then they would be referred on to the tertiary hub if appropriate. So the aim of this initiative is to get these patients out of the tertiary centres, and actually where they need to go as quickly as possible. One of the patient groups we have traditionally had most difficulty with are patients who probably have lymphoma, and we'll see scans and there'll be lots of lymph nodes, and we'll think, you know what, that's probably a lymphoma. We end up biopsying them, but actually that delays their presentation to a haematology service quite a lot. The pathology is very specialized, and if we do a biopsy, inevitably we will look at it, and our pathologist will say, well, it's a lymphoma, but it's specialized, so that has to go off to a haematology pathologist, and that adds several weeks to the process. Traditionally, the haematologist won't take these patients directly from the sarcoma service unless we've proved it's a lymphoma, but they do take them with suspected lymphoma from primary care. So we've had the occasional patient where we've said, actually, we think this is a lymphoma, you should redirect to haematology, because ultimately that will be faster for the patient. So that's the pathway as is. And so here we go. So this is for adults over 16. So children should go directly to a paediatrician, and there are different standards for that. So if you think a child has cancer, they will be seen by your local paediatrician very quickly. If they're over 16, you should go for a direct access ultrasound. And these are the traditional things on this side that suggest a soft tissue sarcoma. It is said, although these have been unpicked over the years, and it's not a terribly good way of picking them up. But anyway, if it's getting bigger, if it's large, so arguably 5 centimeters, although if it's on the tip of your finger, we'd probably accept a lower threshold for that. Painful and deep, these are the things that we worry about. And then you should be able to access local imaging. Yeah. Then you get the outcome of the ultrasound, at which point they can come straight to us if they're highly suspicious or confirmed as soft tissue sarcomas. So that means possible recurrence or a high risk of sarcoma because they have had previous radiotherapy. If someone's had radiotherapy to the breast and they have an area that looks like persistent bruising or an angiosarcoma, if they have Leaf-Rauh which is an inherited p53 defect with an associated high risk of cancer, neurofibromatosis, Gardner syndrome. So these things are syndromes with a higher risk of sarcoma, so we'd be happy to see them directly and work it up. But most patients could go to a local diagnostic service where they could be further investigated and biopsied. So essentially, we are asking that everybody who's referred in has imaging, ultrasound and or MRI, unless it's exceptional. And there's always somebody on call, certainly at Stanmore, who could take a phone call if you're particularly worried about a patient. These are broad brushstrokes as ever. And I think what is needed, the thing that always cuts through, as far as I can see, is a phone call from somebody to say, look, I'm worried about this, or I've tried, this is ridiculous. I've tried to, this is almost certainly a lipoma, and yet I'm being driven down this pathway. What can I do? So I've had phone calls like that as well. So just some examples, if it's helpful, of the sort of common patients that we see. A 35-year-old with a subcutaneous lipoma bigger than 5 centimeters. It says, the ultrasound says likely to be a lipoma, but sarcoma can't be excluded. And if you're looking for a second income stream, to think about setting up a private ultrasound service where you can do lots of scans and not take any responsibility, it seems. Anyway, in which case a local MRI is the sensible thing to do, and that usually gives us the information we need to reassure that patient that they have a lipoma. Of course, if they don't, then we'll take appropriate action. Small indeterminate lesions in the skin, we get a few of these, and very often they would need an excision biopsy. If an excision biopsy of a subcutaneous lesion shows a sarcoma, we can deal with that. So we can do a wider excision, and we can remove the deep fascia if necessary and take that all out. And so it's not unreasonable for small indeterminate things to go to a dermatologist or a local lumps and bumps service if they're in the skin. That's absolutely fine, and we can deal with that if it turns out to be a sarcoma. 43-year-old ultrasound says an ill-defined fatty lesion on the hip, an MRI again is a sensible thing to do. And just a little plea about bone tumours. So we've recently had a referral just like this. So an elderly gentleman living a long way from Stanmore with something on an X-ray that could be that could be a tumour is much more likely to be metastatic bone disease than a primary bone sarcoma. And so the majority of patients like that, particularly if they have a history of cancer, would be better served by either going back to their oncologist or going to a non-specific symptom pathway where they would get worked up. And the major things like prostate cancer, possibly myeloma, that sort of thing would be worked up and excluded. We can do that at Stanmore, but it's resource intensive, and they don't need to come to us. They need to get through oncologist quickly, more often than not. And local hospitals should all have an orthopaedic surgeon with an interest in metastatic bone disease, at least in theory, where they would be able to be seen and worked up appropriately. And of course, we do take some of these patients, particularly the ones that need more complex surgery. So I think that's kind of that. We do have some FAQs there, but I wonder if that's a good point to kind of throw things open for discussion.
Sorry, I had problems getting off my mute then. Thank you very much. Okay, well, I've got a few questions, but let's open to the floor first. Anyone got any queries, questions, experiences, sort of case stories they want to tell us about? Or there may be issues that you've had with getting direct access imaging, and it'd be really good to hear about those. one of the things I don't think we've quite got right yet, Craig, is if a patient is referred for an ultrasound in primary care, depending on how you access the imaging, sometimes these requests get into a more of a routine list, and then weeks will pass before that image, or several weeks will pass, and then, as you say, sometimes we need an MRI after that. And so I'm just wondering how often you're aware of that happening yourself, or when you alluded to, you were talking about some of the real presentations of sarcoma and how many times people had been having to access different services to before they reached you. I wondered if there are any particular themes that you want to share with us around that, or aspects of history or aspects of anything else that should alert us to a more speedy response onwards.
I think it's really hard, isn't it? Because as a sarcoma community, we spent years going around saying, "Don't miss this, don't miss this," right? And now we're kind of seeing, this is to some extent a response to that, I think. Although it's also driven by the sort of 2-week wait, the 2-week wait philosophy, if you like. I think there are some urgent imaging pathways which are not 2-week wait cancer pathways. So we've certainly come across those at Whittington and elsewhere, where you can say, "I'm worried about this," and the patient needs an urgent scan. And that is a nice idea. And if that's widely available, that's probably what you would want. But I appreciate it isn't always. But I guess that would be the ideal answer, which would be that you can get an urgent ultrasound. If it takes 3 or 4 weeks, that's probably okay. If you're really worried about it, then obviously you can pick up the phone. And we are not the semantics, I suppose, are important, but we're commissioned to take 2-week wait referrals, so we cannot reject them. But what we often do is say, look, this is a more appropriate route for that. And if you're getting a response from us that is not appropriate, please do pick up the phone. Or if you're worried about it, please do pick up the phone. Appreciate it's very hard to get people on the phone, and both ways, it's very hard to get people on the phone. We found the directory of numbers, so on the website. So we've got, we do find it a lot easier to ring GP practices now. I appreciate it's not easy, but there should always be someone at Stanmore who's on call who would be able to answer some of these questions. If you're really worried about a patient.
What would be their title, Craig? That on-call person. What's that?
The on-call sarcoma person. Yeah.
Right. Okay. Fine.
Registrar, and if the registrar's not around, it often gets escalated. I mean, I take a lot of calls when I'm on call.
Yeah. Thank you. Can I bring in Mina, please? She's got her hand up. Mina, do you want to speak your question?
Yeah. Hi, Craig. Thank you for the presentation. It was really interesting. I've got 2 questions, actually. I think, are you concerned about delays being, I guess, the reason why a lot of people use the 2-week wait pathways is because we have a awareness that these patients have been referred and they're going to be followed up and something will be done within 2 weeks. Whereas with referring patients for urgent ultrasound scans or for MRI scans, those weeks can often be much more than 2 weeks. It might be 4 weeks or 6 weeks, and then if they need to be then referred on for an MRI after an ultrasound scan, it can be even longer. Are you worried about the effect that might have on preventing early diagnosis of sarcomas?
So there's obviously a balance to strike, but given that 97% of people don't have sarcomas, then that seems reasonable. The safety netting is really important. So the patient who's waiting for a scan, whose lump changes, obviously, needs to be escalated. But I think, I suppose the most common thing is the subcutaneous lipoma, which on clinical examination is fairly characteristic. So if you see the subcutaneous lipoma of any size, then, I wouldn't be particularly concerned about waiting 4 or 6 weeks. If it's a big, deep lump and obviously very painful, and if the patient is at high risk, then yes, these are things that are, appropriately expedited. But most of these things are, lumps that have come up, that have been there for a long time. And so waiting 4 or 6 weeks for a scan is probably the compromise here, But I think the safety net is important, as it is for us. I'm very conscious of the fact that if we redirect a lot of things, we may miss something, right? And so, but the tension for us is that we have a lot of sarcoma patients that we are not, this is affecting our ability to manage these more complex things, our sort of core business, as well as we might, I think, and the MDTs is definitely a good example of that. We don't have the headspace to do it because we're dealing with a lot of benign stuff, and it's a full-time job for 3 people, and lots of radiologists. So our sarcoma patients, people with definite cancer, are waiting longer for scans and everything else. So somewhere, there's no ideal, there's no right answer here, is there? But I think the other thing is that, it's definitely a problem for the patients with benign disease getting referred to a sarcoma service. It's hugely anxiety inducing for a lot of people. So I think, I appreciate it's difficult, but we do find, simple things. I mean, people will often come to us and say, well, no one ever examined me, this sort of thing. And I appreciate that recall is not perfect. But I mean, there are, that's a not uncommon story to have people say, I've been several times and I wasn't properly looked at, et cetera, et cetera. And then often a physiotherapist will see them and put a hand on the knee or whatever for the first time. So it's probably about, clinical judgment initially about those questions.
Yeah, that's great. And my second question was about, do you think that there is sufficient expertise in these external people who are doing ultrasound scans who aren't sarcoma experts to pick up sarcoma effectively?
So I think the third-party ultrasound providers there is a question about, because the quality of reports we get is very variable, and we have engaged with some of the providers with that at a local and a national level. But what we're with the specification for a diagnostic service that we've built up there, that is they are people who should have that expertise. They should be on the money, right? So if someone has an ultrasound, even by someone who's not experienced, that says they're not sure, then they would go to the next level of investigation.
Thank you.
Any other questions? Have people got their hands up?
There's a question in the chat.
Sorry.
Yeah,
there's in the chat.
Thank you. Yeah.
Yeah,
okay.
Which is
can you see that? Do you want to speak the question, or shall I do it? It'd be helpful to know when to refer for urgent imaging as opposed to routine, when the majority we see are lipomas, currently waiting 4 weeks at best for urgent at local trust, third-party provider much longer. Yeah. Can you give us an answer?
Yeah. Well, again, it's about clinical assessment. I mean, it's similar to the previous question. I think it's about clinical assessment and, rapidity of growth, whether it feels superficial or deep, whether it feels clinically like a lipoma,
or like a bone.
Whether it feels firm and deep, or if it's if it feels superficial and soft like a lipoma without any hard bits in it, then it's probably reasonable to wait. But I think, if you're worried about it, if it's, for example, fungating, or somebody who's previously had a sarcoma, or they're at high risk, or they've had radiotherapy, then these things are urgent, because the risk of that being a sarcoma is much higher. But ultimately, these remain, these are very rare things, but one doesn't want to miss them for sure.
Do you think, thinking about this in the context of primary care and clinical assessment, Craig, do you think that for those that are truly sarcomas, or in fact sometimes metastatic disease, would you say that one of the things that you often see is a physical, reasonably rapid change in growth or size or shape, and so continue trying to set up, if you're not sure, a repeat examination review appointment in the very reasonably near future that we measure in weeks, not months, can be helpful? So if you think it's not a problem, but you'd like to introduce a bit of an opportunity to make that decision a bit more robust clinically, do you think it's appropriate to see those patients again yourself in a 2-week time frame? I'm certainly thinking of one patient that I've seen recently, and I've been practicing now 30 years, and I think I've never seen this until this month. It's an issue with a patient who's very well 70, but presented with a slight bony increase in size and shape of the sort of sternoclavicular junction on, slightly on one side rather than the other, slightly more to the right. Absolutely non-tender. Not patient looked incredibly well. But I saw them in the non-specific symptom service, and so I was able. They had, they went straight to. In fact, what they had, because they had some other issues as well, but they had a CT cap. But what we saw was an aggressive tumor. But one of the things that really struck me was that the visible change in the tumor in examination in a time frame of about 8 days was very obvious to see as a clinician. So I just wondered how often you see that rapidity. I guess if I'd been in a primary care situation, I could imagine deciding to see them again 2 weeks later, because prior to that time, the number of patients I've seen in my clinical lifetime with just that first initial sign are very many, but the difference was that there was no change over time.
Yeah, I mean, that's interesting, isn't it? I was sure you were going to say sternoclavicular osteoarthritis, because that's the ones you see lots and lots of, right? And an ultrasound will make that diagnosis.
Indeed.
And that's, and then an ultrasound, and then you're fine. Everyone's reassured.
Yeah.
So I think
the message to me was the change at being able to. So what I saw this time was and obviously because of other reasons, I've seen them in a different setting. I've seen this patient several times, but the rapidity of change of shape and size of the growth has been is one of the kind of really obvious clinical things. And so, but I'm wondering whether, because now in general practice, it's really quite challenging sometimes to ensure clinical continuity, and rather than asking the patient to put the appointment, I'm just wondering about whether you would be recommending that if where we think it's osteoarthritis, but we want to have a bit more of a clinical recheck, would you say that it's a sensible thing to have clinical continuity and a re-examination at X number of weeks later, and when might that be?
So I mean, I must say, it's I've been working in primary care. You're past masters at safety netting and using time as a kind of diagnostic tool, right? I mean, that's kind of that's very much what people do, isn't it? I think it's difficult to be prescriptive. Again, I think you have to make a clinical judgment with that sort of patient. I mean, we get referrals like that of patients where we're not sure it's indeterminate, and sometimes we see them back. But we make a judgment on how long they've had it and whether it's symptomatic. And usually, I guess it's slightly unreliable piece of the history. How quickly has it been growing? Because pretty much everyone will go, "Oh my God, it's just appeared," right? And so that's quite difficult, even with the lipomatous tumor that has been there for years. That the patient may have lost a bit of weight or has just noticed it for whatever reason. So I think that is always difficult, isn't it? But it's about clinical judgment. So one would hope that if that patient had suddenly grown and you said come back in 6 weeks, but it was bigger next week, then you would hope they would have access to let you know, and then you would escalate. And I think again, it's about the guidelines, and this are all very well, but it's quite hard to be absolutely prescriptive. And I guess what is needed is some I suppose a decent history and examination and some clinical sort of assessment.
I mean,
really.
I was this particular patient was so well, felt so well.
Yeah, right.
It was extraordinary. I didn't. In fact, my first thought was there's a mix-up here between the report and the patient. I really was so surprised to see it. So, and as I said, because I've seen lots and lots of osteoarthritis.
And what was the diagnosis?
They're on the way to you.
Oh, well, there's sarcoma.
I'll talk about it later. Yeah.
Okay, fine. Yeah.
So yes, that's the so I don't know if anyone else has had any other sorts of stories like that, or any the messaging for me. I only brought it up because we were talking about examination, and I wanted to ask you whether, certainly my experience particularly in that story, the message was the opportunity to have continuity of care of examination within a very short time frame would have been very helpful to me if I'd been in the primary care environment. Because if I had seen that patient in primary care myself, that very first time, I would not have thought that it was going to be a bad diagnosis. Would not have thought it at all.
I see Mustafa's on the line.
Yes,
Mustafa, I don't know if you want to talk a bit about Wood Green. So Wood Green was set up as a pilot to help with some of this diagnostic work in the community. Do you want to say where you're at the moment and how that relates to primary care?
Sure. Hi everyone. I'm Mustafa Hassan. I'm the general manager for the Wood Green Community Diagnostic Centre and also head of radiology at the Whittington Hospital in North London. So we started working with our colleagues at RNOH in developing this sarcoma diagnostic pathway through the CDC. I'd say probably around sort of March times this year. We've had some uptake of the service, which has gone really well. And for those patients who've gone through that pathway, they've then gone on to, we've had a few patients with positive diagnostics and have gone on to RNOH to be treated. So we have had a significant impact on those patients, the small numbers that have come through our pathway. But what I'd like to help sort of clarify for our colleagues, the GPs on this call, is how to make best use of Wood Green. So essentially, Wood Green is there to support RNOH with urgent diagnostics, referrals coming from the GPs with patients who've got a significant finding on an ultrasound performed locally. Wood Green is also available for our local providers around us to send patients in for their initial ultrasound as well. So we just want to make that clear for the GPs in our local area that Wood Green is an available option for them rather than sending the patients to the secondary care. But predominantly Wood Green is there to help speed up and turn around urgent diagnostics, things like ultrasounds and MRIs in particular, and turn them around within 3 to 5 days from referral to report, so that the GPs have the information available to them to then make the onward 2-week wait referral to places like RNOH. So essentially, we are open to receiving those referrals, and we're happy to send some information around the referral guidelines and pathways, so that you have the tools available to you to then make the urgent imaging referrals to us.
Thanks so much, Mustafa. Thank you. And you've now got all major modalities, imaging modalities there at Wood Green, haven't you?
Yes, we offer CT, MRI, ultrasound, and also X-rays as well.
Yeah. Yes. So, any questions? Otherwise, I've got another question for Mustafa, but I can.
There's a question about the waiting times for
Arup. Yes.
MRIs at Wood Green.
Yes. We could turn around these patients within 5 days from referral to report. So that's the KPI that we have internally to deliver that. So we have a very quick turnaround time at Wood Green.
If I can ask a supplementary question about imaging and then go to Arup. Arup, in a second, I'm going to ask you to speak your question. So if a GP requests a CT CAP, CT chest, abdomen, and pelvis, or in fact CT of any description, but they don't request contrast, and in fact you know that contrast will provide a better image. Can you tell me what do you decline the referral, or do you contact the sort of primary care and say, actually, this would be a better image if there was contrast, and have a dialogue about it? Because really helpful if you could clarify that for GPs.
Sure. So all CTs, and also including MRI and ultrasound, we vet all our referrals that come through. Yeah. So it's vetted either with ultrasound, it's vetted by the lead sonographer, and with CT and MRIs, they're vetted by the lead radiographer and also consultant radiologists. We have a consultant radiologist on site every day. So they ensure that we're appropriately vetting referrals, making sure that if patients need contrast, that they get contrast at the time of their scan. So we don't reject any referrals. We don't reject any referrals, yeah.
Thank you. That's really helpful. So Arup, do you want me to speak your question, or will you be able to?
Hello there. Hi. Yes, I've just
Thanks.
put my mic on. So
Thank
yeah,
you.
it's quite self-explanatory, but I don't know if it is a silly question. But when I was training in the last few years, I would see lipomas sort of all over the body, particularly on the back. And one of the sort of differentiating factors I found to scan patients would be when they were complaining of, quite severe pain. But a lot of these scans came back as, it's a benign lipoma and there's nothing to be concerned about. But in terms of like the pathophysiology, why do some hurt and why do some don't?
I mean, traditionally angiolipomas are a bit more painful. So that's the lipoma variant that has pain associated, sometimes multiple. Derkham's disease and multiple angiolipomas.
Yeah.
So that I suppose is why. But I mean, you're quite right to scan the ones where you're worried about it, and that's completely reasonable. But probably not on a 2-week wait pathway.
Sure, yeah. I wasn't doing a 2-week wait.
Message. It's kind of the message, isn't it? But as long as you can get a scan in 5 days, right? So
yeah. Okay, thank you.
Thank you. And then following on from that, Craig, what about clinical signs for liposarcomas? I know they're very rare.
So liposarcomas are just a variant of soft tissue sarcoma. So although it's quite it's a big bucket of different stuff, you'd be looking for the same as any other. So you'd be looking for a large, deep lesion that is growing more often than not. To have a subcutaneous liposarcoma would be extremely unusual, like a really rare
very
thing.
Rare. Yes.
I mean, there are, subcutaneous lipomas we do see, or subcutaneous sarcomas we do see, but the majority are deep. I suppose the more common ones that we would see would be a thing called a DFSP, which looks like a little purple volcano, but that looks very dermatological if you see it for the first time, and they're very often sent to dermatologists quite appropriately as the first step. But I think large, deep things where the skin is very tented over the top or they're beginning to fungate, these are things that we should see for sure.
Right. Okay. Thank you. I don't want to hog all the question time, so I'm scanning the questions and the hands.
Another hand up. There's one other hand up there I can see. Yeah.
Thank you. Whoever that is, please talk. Please speak your question. I can't see it on my list, so whoever it is, please just speak.
Svetlana.
Thank you.
Yeah.
Oh, Svetlana.
I don't know whether you can see me. Let me just see. Yeah, you can see me here. Hi.
Yes, we can see you now. Hi. Yeah.
Hi there. I just want to ask Mustafa. I work in Haringey and we use Whittington Hospital and Wood Green as well. I'm always confused when we refer patients to the Whittington Hospital. Sometimes they say we went to the Wood Green. Are you the same people, the same team?
Sure, I can clarify that. So Wood Green is hosted by the Whittington. So we are supported by them, but referrers can refer into the Whittington and also Wood Green. Whittington utilize Wood Green to support with capacity. So patients are sometimes referred to the Whittington and then are given appointments at Wood Green because the capacity is available to see them sooner. Wood Green is also supporting with backlog recovery for all the other NCL trusts as well. So for the GPs that refer to places like the Royal Free, UCLH, North Mid, some of their patients do come over to us to have their diagnostics done.
I see. I mean, to be honest, before I used to use InHealth when I have like suspected lump. But as I agree before with Craig, they said lipoma, but sarcoma cannot be excluded. Then we will use then the pathway to send to the Whittington Hospital, and then just kind of you are doubling the investigation. So now I usually refer to the Whittington if I feel that somebody needs to help.
Yes.
And I'm quite reassured that they have pathway. If it is benign looking, they will not really need, they will kind of be protest if it is suspected. And I'm glad to hear that.
Sure. Yeah. I mean, with my Whittington hat on, we do get a lot of patients being re-referred for diagnostics after they've gone to a third party. So that's having an impact on our general diagnostic capacity, having to repeat imaging. So we're more than happy to take on that work from a Whittington perspective. And also because you're in Haringey, your team can also refer into Wood Green for the initial diagnostics as well, because we're a local provider to you.
Thank you.
Can I just check though, I'm sure this is the case, but just to repeat it for everybody, if people aren't sure, Mustafa, anyone in NCL can refer to you if the patient is happy to travel to you, can't they?
Yes, yeah, we want to offer patients.
So I think that's the
flexibility.
important. Sure, that's because we've only got 2 CDCs in North Central London geography. So so for everyone on this call, you can refer to either one at Finchley, one at Wood Green. And sometimes we certainly find patients much prefer the smaller environment, don't even suffer of the CDC, and compared to some of the bigger institutions image. So and it's less, people report it to us as less frightening, more welcoming, easier to get to within the community.
Yeah, patients do really enjoy coming over to Wood Green, and I think I just want to stress that for lumps and bumps, if there are any concerns, please do use your local provider. Wood Green is available for our local providers, but also we provide the urgent suspected cancer for sarcomas at Wood Green. So it's just to spread that message and make it as clear as possible for everyone.
Thank you. I can see that Marina, we're into the last minute or so of the talk, but just Marina from Westbury Medical Centre has said that she ended up waiting a month for an MRI report from Wood Green. Is that happening regularly, Marina, or is it just a one-off? I don't know if she can hear us. But it might.
I'm happy to take that away.
Take it away. Thanks, Mustafa. That would be good. Yeah. If you could take it away, maybe you can see Marina's address there on the just on the chat. So perhaps you could email. Maybe. Thank you. Okay. Well, we're at 1 o'clock, and we need to finish because that's our time slot for the day. And everyone's got off to go off to other things. But thank you so very much, everyone, for attending. Thanks, Craig, and the team.
It's a pleasure.
For coming, and thanks to the Alliance team for putting on the webinar. And any extra, so for any of you on the call, we're always, as you know, we run a program of different webinars, but anything you particularly would like to hear about, please just put it in the chat before you leave us today. And any feedback and any sort of topics that you signpost, will make sure that in due course we cover them. Thank you very much, everybody. Thank you.
Thanks.